السلام عليكم. اليوم راح تكون محاضرتنا عن الجراحة مالت مرحلة رابعة، والموضوع هو الرينال انجري. راح نحكي الرينال انجري. Renal injury are the most common organ to be injured during from the urogenital system. Mostly the injuries occurs from external trauma, and it occurs in 10% of all abdominal trauma and in 1 to 5% from all trauma patients in general. So 1 إلى 5% من البيشنتس اللي عندهم تروما راح أكون الكدني راح تكون injured، و10% من البيشنتس اللي عندهم abdominal trauma راح يكون عندهم يعني suspected or to have kidney injury. The kidney is protected by multiple structures to protect the kidney itself. First is protected by a layer of fat that covers the kidney itself to protect it. Second, anteriorly, all the viscera and the anterior abdominal muscle protect the kidney. From the side, laterally, the kidney has the lumbar muscles to protect it, also the vertebral bodies and the ribs. So all these structures protect the kidney. The etiology of renal injury, we have two processes that the injury could be, the kidney could be injured. First, the kidney could be predisposed to blunt trauma or penetrating trauma. The blunt trauma is more common. 80 to 85% of all renal injuries are blunt trauma. It can happen through motor vehicle accidents, through falls, through contact sports. So the blunt trauma is more common than the penetrating trauma. The penetrating trauma is less common. It includes gunshot wounds or stabbing wounds. Those are the causes of penetrating trauma. We're going to classify the severity of the renal injury according to the AAST severity scale, which is the American Association for Surgical Trauma. هنا عندنا normal kidney بيها هذا الكبسول مال الكدني، هاي الكورتكس، وهذول الميدولاري بايرامنتس اللي هي الميدولا، وعندنا هم البلفوكاليسيال سيستم اللي يشمل لنا الرينال بلفس واليوريتر والسيجمنتال رينال ارتري والرينال ارتري. This area here, which is the renal pelvis that continues into the renal ureter and the renal artery is called the hilum of the kidney. Grade 1 of the severity of the renal injuries is the most common grade. It includes only contusion without laceration. Contusion is a superficial bruising to the kidney without laceration, and the laceration means cut. So in this grade 1, there is no cut, only superficial bruising and blood accumulation below the capsule. So it's pre-capsular hematoma collection, which is blood collection, and only contusion. This is grade 1. Grade 2, there will be laceration only confined to the cortex. So the medulla will not be reached by the laceration. This laceration is less than 1 centimeter with blood collection outside the capsule. So we have hematoma collection outside the capsule called a pre-renal hematoma with laceration less than 1 centimeter, does not reach to the renal medulla. Grade 3, where the laceration is more than 1 centimeter and reaches to the medulla but does not reach to the pelvocalcial system. This is grade 3. Grade 4, where the laceration goes through the renal cortex, into the medulla, into the pelvocalcial system, and lead to extravasation of urine, or could be due to injury to the segmental renal artery. So it's either a laceration throughout the whole renal cortex, into the medulla, into the pelvocalcial system, or injury to the segmental renal arteries. This is considered as grade 4 injury. Grade 5, which is the most severe injury, sometimes it's called shattered kidney, where the whole parenchyma of the kidney is injured, or the renal hilum, which contains the renal artery, is avulsed. if the renal artery is avulsed or the laceration, the whole parenchyma of the kidney is disrupted, it's a grade 5 and it's considered shattered kidney. Now we're going to talk about how the patient will present to us. So هذا البيشنت شلون راح يكون عنده من presentations for us to suspect that they have renal injury. First is symptoms. The patient can have visible abdominal trauma, because we said the renal injury may be due to blunt trauma where we can find a bruise, or penetrating trauma when there is a clear visible wound at the site of the kidney. Second, the patient may have pain that could be localized to the flank area or could be generalized throughout the abdomen. Third symptom is associated injuries, because we said that the kidney is mostly injured when there is a generalized abdominal trauma, so other viscera in the abdomen could be injured, or even in the pelvis. Fourth is hematuria. Patients sometimes presents with bloody urine when they have a renal injury, but the hematuria is not corresponding to the severity of the injury. So sometimes the patient have a very small amount of hematuria, but so we think that the kidney is not injured severely, but it's not correct, because sometimes there is a severe renal injury but with very small hematuria or no hematuria, so they do not correlate. Final presentation, the patient could have retroperitoneal bleeding and retroperitoneal hematoma, which can lead to abdominal distension and acute abdomen and peritonism. These are the symptoms that the patient could have if they had renal injury. Now we're going to talk about signs of renal injury. First, the patient could have shock because of the continuous loss of blood by forming the retroperitoneal hematoma, which can lead to shock. Second, the patient may develop ecchymosis around the area of injury, especially if the patient had blunt trauma. There will be ecchymosis around the flank area. Third, there could be diffuse abdominal tenderness during palpation. And finally, the patient may have a palpable mass due to the collection of blood through retroperitoneal hematoma, forming a mass of blood loss. Here we have a patient who has flank ecchymosis as a sign of the patient could have renal trauma. Now we discuss how we investigate patient. Now the patient presents to us with signs and symptoms that makes us to suspect that the patient has renal injury. So how do we confirm our diagnosis or exclude our differential diagnoses? First is, we have two methods of doing investigation. First, we can have laboratory investigations, and second, we could have radiological investigations. Regarding the lab investigations, we can do investigations to the blood and urine. In the urine, we can find hematuria, which I said is a symptom or a sign of renal injury. Second, we can do blood investigations, which show us a decrease in the hematocrit because of the blood loss during the injury. In radiological studies, we have different methods to do radiological studies. First is by CT scan, contrast-enhanced CT scan, which is the gold standard of investigation in patients with or suspected with renal injury, because CT scan can show us the parenchyma, the outline of the kidney, if there is any extravasation, if there is any fluid collection, and the surrounding viscera, if there is viable or non-viable tissue, if there is retroperitoneal hematoma. CT scan is the best method to diagnose these conditions. We have other radiological investigations, for example, IVU, which is intravenous urography, or ultrasound or angiography. These are also radiological methods of diagnosis renal injury, of diagnosing renal injury, but they all are secondary to the CT scan. So if the CT scan is not available, we do these investigations. Here we have some examples of CT scan axial section of the abdomen. Here the patient have, for example, this one. The outline of the kidney is disrupted from this area with fluid collection here, a hypodense area. In this example, we have a confined, well-defined fluid collection. It could be a subcapsular hematoma. And here we have a completely disrupted renal parenchyma, which could be stage 5. A renal injury could be a shattered kidney. Now, how do we manage patients with renal injury after we confirmed our diagnosis? How do we manage them? There is different lines of managing patients with renal injury. First is the emergency measures, and second, we can have operative and non-operative methods. In general, with renal injury, we always tend to do a non-operative management of the patients, whether the patient has a blunt trauma or penetrating trauma. 30 to 50% of patients with even penetrating trauma can be managed conservatively without operations. This is our approach. But in patients, when we choose to do non-operative management, we need to keep the patient under close monitoring and observation, and we need to do a series of actions in patients that we keep under our vision when we're considering non-operative management. First is serial hematocrit studies, because after the injury acutely, the hematocrit could not be changed. But after that, with the continuous blood loss, the hematocrit could drop. So we need to do serial hematocrit studies. Second, we need to keep the patient on a strict bed rest until the hematuria is resolved. And third, we need to keep the patient on re-imaging. So in the initial imaging after the trauma, يعني إذا البيشنت عنده trauma أول ما أسوي له imaging ممكن يكون normal شكله، بس ورا فترة نعيد imaging studies وهنا راح تبين إن البيشنت عنده actually trauma. Finally, the fourth, the patient could have delayed bleeding. So sometimes the patient, in the beginning, they have trauma, but it's not visible, or it's not indicated. Usually the patient hemodynamically stable. بس ورا فترة, sometimes from 1 to even a week, the patient sometimes develops late bleeding or hematoma formation and then shock. So إذا patient خليه تحت non-operative management لازم أسوي كل هاي اللاينز حتى أتأكد إن the condition of the patient is not deteriorating. But we have some absolute conditions where surgery is mandatory. First, إذا البيشنت is hemodynamically unstable, لازم نسوي له operative management. Second, if there is expanding hematoma, so احنا نسوي له radiological study, نسوي له hematocrit ونشوف إن الهيماتوكريت باقي ينزل، الهيماتوما بعد هي تكبر، هنا نسوي operative management. Third, إذا أكو suspected renal pedicle avulsion. We mentioned that the renal pedicle is the area where the urinary pelvis comes out and the renal artery comes in. If this area is avulsed or injured, then a surgical intervention is mandatory. We have a different method of treating patient to avoid surgery, because always our method or our way of treating or handling patient is to avoid surgery as much as possible. So we have this method, which is interventional radiology, where we localize the exact blood, that's the exact vessel, that's bleeding, and embolize this vessel to stop the bleeding and just avoid major surgeries in general. Renal injury and renal surgery can have different complications. The complications could be early or could be late. The early complications, the patient may have hemorrhage, which is blood loss. They may have urinary extravasation, and they could have a pre-nephric abscess, which is accumulation of pus and infection in general, and pus. And finally, the patient may have infection and sepsis. These are early complications. Also, the patient can develop late complications. For example, the patient could have hypertension. Also, they can have hydronephrosis, which is enlargement of the bulbocalyceal system. They could have arteriovenous fistula, fistula is a communication between two epithelial surfaces. So there is an abnormal healing of the artery and vein where there is a communication between these two, which is the arteriovenous fistula. There could be calculus formation, which is a stone formation. There could be pyelonephritis, which is infection, and there also can happen, bleeding can also happen, which is late. Sometimes the patient after 1 to 4 weeks, they can have late bleeding and reduce in the hematocrit. Now we finished our lecture about renal injury. We discussed what's the etiology of renal injury, how the patient presents to us, their signs and symptoms and clinical features. We discussed how we investigate and diagnose renal injury and exclude other diagnoses, and how we managed renal injury. Thank you.